So let's start with capnography. There we go. So we use capnography and pulse ox, and we kind of use it in combination because you can get a lot more information from capnography, but pulse ox also provides you a decent level of information about your patient, including how well they're perfusing. So if you have a patient and you can't get a good waveform on the pulse ox, there's the concerns that, oh, maybe that they're cold, maybe they have, nail polish on, or any number of those things. But if you take the blood pressure and it's like very low, your pulse ox can confirm how poorly they're being perfused to the end tissues. Quick little case study for you guys. Dispatch to a patient complaining of difficulty breathing. Upon arrival, you find an obtunded female in respiratory failure. You're unable to get information due to patient status. SpO2 is 90% on room air, 94% on non-rebreather. Lung sounds are clear all fields, and you decide to intubate the patient. You visualize the tube passing through the cords and achieve equal, adequate chest rise with easy ventilation. Your end tidal registers at 20. Okay. Initial thoughts. What do you think is going on with this patient?
Well, she's hypocarbic.
Mm-hmm. Right. Her end tidal, for those of you who are like, what is hypocarbic? Her end tidal is low, which means that she has blown off a significant amount of carbon dioxide.
So she's obviously having issues with ventilations and gas exchange.
Okay, on which side? Like the internal or external respiration?
This is where I'm not seeing a waveform, which might give me some indication.
Okay, but like think it through, right? You've got good lung sounds. Right. You've got good lung sounds, and your end tidal is 20. So her lungs are clear, but
I'm gonna say internal.
Okay, good.
Wait. I always mix up carbon dioxide and oxygen. Which one's the acidic one?
I'm dying. Say that again.
See,
with carbon dioxide is acidic.
Yeah, there you go.
So she's so she is in acidosis.
If she was in acidosis, her end tidal would be very high. She blew off too much acid. She does not have a lot of carbon dioxide.
All right, so then she's alcolytic.
Yes, perfect.
So is she like hyperventilating basically? She's just breathing too quickly?
There's a possibility. There you go.
Diabetic ketoacidosis. I mean, God damn it. Diabetic. Fuck it.
No, not diabetic ketoacidosis. You would expect her end tidal to be much higher. You would be so your normal end tidal range is 35 to 45. If she was diabetic ketoacidosis, you would expect it much on the higher end. Just like if you had air trapping, like from asthma or COPD, you would expect a higher end tidal.
Is it possible that it's not disclosed here, but she might have some sort of cardiac issue that's impairing the
Okay, good. So what's the easiest, most general cardiac issue that you could think of that she might be experiencing?
CHF.
Okay. CHF, so she can't, right? There's a poor perfusion of the carbon dioxide back into the lungs, right? You have that obstruction.
Right.
What else? Maybe she's a
pneumonia.
Pneumonia. Okay, what else?
Kind of dysrhythmia.
Okay, dysrhythmia. How about just, as I said, speaking kind of general, just poor perfusion.
Shock. Cardiogenic shock.
There you go. Or any kind of shock, right? You might end up with a patient who is significantly who doesn't appear to have a good waveform. Okay? What other things might you be concerned about?
If the tube was placed in correctly.
Beautiful. There you go. Are you in like the right main stem or left main stem? It says you have good chest rise with easy ventilation. What about a pneumothorax?
Right,
Could you have, a potential like a pneumo-hemo kind of setup where you can't get, you have good compliance, but you can't hear it yet, right? It's not necessarily bad enough that you can feel or hear it with your ventilations. Okay, good. Hold on to that because we're probably going to revisit that. Capnography is your vital sign for ventilation and internal external respiration, right? So you want to know that the blood is going round and round and the air is going in and out. That's pretty much what capnography is telling you. If there's some sort of kind of variation in that where you don't have good perfusion or you don't have good mechanical ventilation, capnography is going to show it to you, and it's going to show it to you like a very sensitive manner. The whole idea behind capnography is that it gives you a non-invasive measurement for how much carbon dioxide is in the exhaled air, right? The partial pressure. So we talked about the rules of partial pressure previously in the last class, and nitrogen is your number one, component of air. 21% is, your oxygen in regular, breathing air. Carbon dioxide, your body produces it, and then you can get a good measurement with it from capnography. So it gives you immediate information about ventilation, right? How effectively the lungs are working. So we talked about this already a little bit, right? CHF, pneumonia, any sort of issue inside the lungs that will prevent that diffusion of carbon dioxide or oxygen across the pulmonary capillaries. It also will give you an idea of perfusion, right? How effectively is the oxygen and carbon dioxide being transported? So shock states, you're not going to have great perfusion, which means that you won't have a good return of carbon dioxide back to the lungs for exchange, which on the other hand also means that you don't have good perfusion of oxygen into the body for gas exchange to the tissues. This is part of the reason that shock states are so dangerous, because not only you become acidic, but you're not getting adequate enough oxygen. And it also gives you a good sign of metabolism, like Rob said, DKA, right? So if you have a patient and they're unresponsive, they're hot, they're red, and their sugar is reading high, and then you intubate them, you would expect their capnography to be extremely high as well. Versus, a patient who, was hyperventilating, or, you put them on blow-by end tidal, right, for a panic attack, and you're going to find that their end tidal is very low because they're blowing a lot of that carbon dioxide off before it can really be measured.
So Nicole, if
Mhm.
someone's CO2 is high and you intubate them, you hyperventilate them a bit to bring down that CO2?
Absolutely, right? Because now you are providing that mechanism of like that respiratory mechanism to blow off, quote unquote, blow off the carbon dioxide. Absolutely. A few different definitions, because sometimes they do like to ask about like the specifics. Usually they really want to say capnography. Capnography is on a graph, right? You get a numerical reading, versus a waveform. The capnometer is just a numerical quantitative. The capnograph is the numerical put on a tracing. This is the gold standard when you are intubating someone, is the capnography, because it gives you real-time information with a graphical explanation, right? So we talked about this a little bit last week, where you can have different shapes of the waveform, and these can tell you different things. So if you intubate someone who in respiratory failure and you see they have a shark fin kind of shape of their capnography, this can help you tailor your treatment of this patient, right? Maybe they have a history of asthma and they've gone into respiratory failure, and you go and you check and they've got this shark fin vibe, and you're like, oh, let me see if I can send albuterol, or maybe I can give them epi, right, to help fix the air trapping situation that's going on in their lungs. So there's a lot of information that capnography can give to you that will help you guide your treatment for the patient. the two different types that we use, the most commonly you're going to see is over here is the inline. It fits right on top of the tube, and then it has the universal sizer, so you put the BVM right on top of it. You need to make sure that no matter which capnography you're using, that you plug it into the monitor first and let it zero. Okay, it's sort of like when you decide that you're going to use you're counting your macros or whatever, and you need to use your kitchen scale. You don't want to put something on the scale and then turn it on, because it's going to assume that that's zero, right? That's the starting point. If you want to measure something, you need to take it off the scale, turn the scale on, and then put something on it. Same thing with your capnography. You need to make sure that the capnography line is 0 to room air, and then it will be able to measure more effectively when you attach it to either the tube, or you use this little magical side stream thing, which just looks really funny. This is the nasal cannula attachment, and it gives you a sampling of what the end tidal is of the patient who is not intubated. I've done some definitely wild and crazy things where I've taken the end tidal part of this and put it right next to the patient's mouth to try to, for those who weren't using a nasal cannula, they were using like a non-rebreather. It works occasionally. It's not as effective as you would think, unfortunately. But you can also have a patient, it's going to sound completely ridiculous, you can have them blow right into this, into the inline, and it will work. It will give you a reading. So if you have a patient who's like on a nebulizer, or and they're inhaling, exhaling through like a small mouthpiece, you can kind of get a little creative to get a good idea of what their capnography is, even if you don't have this available. The side stream, not everyone carries it because they're super expensive. They're like $34 per cannula. So you don't see it in a lot of places. So, kind of going back to a brief review of the anatomy of how gas exchange works. You take oxygen into your lungs. The oxygen then diffuses into your bloodstream and is carried by your red blood cells to your organs. Your organs use it, primarily the mitochondria of each tissue uses oxygen in order to create energy. And when it does so, it produces carbon dioxide. Carbon dioxide then dissolves in the plasma. Very small amounts of them are actually carried on the little rafts of red blood cells. They go back to the lungs, and gas exchange occurs again, where now the carbon dioxide is going into the lungs, oxygen is coming back out of the lungs, and you exhale carbon dioxide. There's a bunch of dead space. So we talked about this a little bit last week. Didn't have a great picture for you, but the dead space is anything that is not an alveoli, right? So you have your little, broccoli florets over here that, is where all gas exchange occurs. Gas exchange cannot occur in your bronchioles, your trachea, all here, but this area is still filled with oxygen or air when you take a breath in. Okay, this is why hands-only CPR works, because this dead space is full of relatively fresh, untouched air that, through chest compressions and passive breathing can be brought all the way down into the alveoli for exchange. About 30% of your inspired tidal volume is in fact considered dead space, but you still need it because it still serves as a conduit to get the air to where it needs to be. So there's a number of different phases of exhalation. So when you guys do intubate, when you do start to do this on the in the skills labs, you will notice that here is 0. Okay, when you're down here in 0, it's either inspiration, right, which is your downslope, right? Because when you are breathing in, the detector isn't going to detect any carbon dioxide because you're moving it in the opposite direction. So you'll primarily oxygen here, oxygen, oxygen, oxygen. That little pause in your breath before you exhale, right? Remember, like when you think about as you breathe, like there's like a little pause for air exchange, right? So there's nothing going in or out, and you're down here at 0 carbon dioxide, right? And then as you start to exhale, your carbon dioxide starts to go up, right? There's a point in your expiration where it sort of kind of plateaus, right? It's like right towards the end of exhalation where you're not really putting out a lot of air. You're about to take another breath in, and that very top point is considered your end tidal volume. This highest number is right here at this peak. Okay, so you have to understand that like you're getting a lot of different vibes, right? You're following the whole course of breathing, but what you're measuring is your expiration. Okay, you're measuring carbon dioxide. So if you were to measure a inspiratory, it would be the complete opposite, right, of what you're seeing here. If you were measuring oxygen, it would be the same thing, except right here would be exhalation, inhalation, and then exhalation again. So here, we'll talk about this a little more in depth. Right here is what's called the expiratory upstroke, right? So it's from when you start to clear the dead space, right? Because there's not a lot of carbon dioxide in the dead space because the air is going in and out and not being modified by your body, right? There's no gas exchange in that dead space. So you have this little bit of kind of non-effect before the carbon dioxide that was in your alveoli starts to show up, okay? Right here you have, this is all of the stuff that was from your alveoli. It reaches the upper airway, reaches that, that inline or side stream measurement, and then it starts to hit right here at the alveolar plateau. Sounds very sexy. Which is where it's kind of primarily all alveolar carbon dioxide, right? It hits that plateau, and this is where it's measured because it's the highest point. This happens, as I said, right before you take another breath in. This number pretty much tells you how well the alveoli are being expanded, right? How well blood flow is getting to the lungs, and how well your mitochondria are actually utilizing oxygen in order to create energy for your body, and therefore creating carbon dioxide. As you have this sharp downstroke, that's when you breathe in, and it's not picking up any carbon dioxide because obviously you're bringing oxygen in. This is your normal value. It also correlates with your normal pH, right? Your normal pH in the body is 7.35 to 7.45, okay? This is for a healthy person. We talked about how hypoxic drive is kind of how COPD patients live. So this is not necessarily going to be what you see when you have a COPD patient. These patients their body will alter and adapt to the higher levels of carbon dioxide, and they can have a baseline of 50 or higher. That can be completely normal for them, but their body has now working in other ways to keep their acid base level appropriate. The one thing that we most primarily use end tidal for is to verify an end tidal or an endotracheal tube. Not only are we verifying that you are in fact in the lungs, but you're also making sure that it stays there, right? So if all of a sudden you start to have a weird tracing, right, a weird waveform, you might have displaced your tube, or you might have somehow accidentally pushed it in and you only have the right main stem, or you might have a mucus plug. Okay, there might be something, right? The patient might need to be suctioned. And this is all of that stuff right here is what that end tidal capnography number and the waveform is going to tell you. That's why we don't rely solely on the number of the end tidal, we use the graph as well because it gives us a lot of information. You also notice that if you have a patient who's in cardiac arrest, if you start to have them, if they achieve ROSC, their end tidal will suddenly spike. This is very commonly due to the fact that now they're perfusing much better, right? The heart started working again. It's getting that blood around the body more effectively, which means it's bringing more carbon dioxide back to the lungs for exchange. You will also see this after you give a patient sodium bicarbonate. Okay, you'll see the end tidal will commonly spike, even if you don't have the patient back. It's that buffer helps, promote getting that acid out of the system a little bit better. Determining sepsis and trauma, you'll have different waveforms, right? So if you have a patient who's got a really poor waveform, who's a trauma patient, they're going to have a worse prognosis than someone who has a really good waveform, right? They're not compensating well. They're potentially extremely hypotensive, right? And those patients are the ones who don't do the best. Same thing with sepsis, right? If you have wild changes in your, I think if it's higher sepsis, that it also if you can determine a patient is septic if they have a very high end tidal, okay? Because you have bacteria that's also creating carbon dioxide in the body. And you can also determine how well you're ventilating the patient, right? If you are delivering an adequate amount of oxygen, etc. So they did a really interesting study in the late 80s. And this is often when you are calling for pronouncement, they will ask you what the patient's end tidal is. Basically, they found that if the patient has an end tidal of less than 10, they will very likely not return. They will not have ROSC, especially after 20 minutes of ACLS interventions. Okay, so you get to the scene, you have a patient who's in asystole, you're doing CPR, you're giving epi, you're doing everything that you have to do, and you tube them, and their initial end tidal is 4. You have good CPR, you would maybe even have a Lucas device, so you've got like high quality CPR going on, right? And you give them epi, and then you give them like the calcium and the bicarb, and you look, and their end tidal is 8. Their patient is not coming back, okay? They have been deceased for quite some time, all right? And so when you call and you say, hey, listen, we had a patient initially in asystole, they're still in asystole, and now, their end tidal started up as 4, and after interventions, it's now 8, they're going to give you no problem, right? Go ahead. You can terminate. Very, very valid predictor for cardiac arrest survival. Questions?
Okay. Nicole, I put it in the chat that if that spike in CO2 if you regain ROSC, would it just be a quick spike, or would remain consistent?
It'll remain consistent. You'll notice, you'll be doing CPR, and the patient's like maybe at 12 or something, right? And then you give maybe you shock and you give an epi, and all of a sudden they'll go up to like 35, 50, something like significantly different than where you started, and it'll stay there. That's pretty much saying like, hey, the heart is back, it's maintaining a blood pressure, like you're doing what you're supposed to do. It's like a very good sign that the patient has return of pulses.
Cool.
Nicole.
Mm-hmm.
So I put in the chat, if a physician is supposed to sign papers for your ED tube, correct?
No.
Won't you go to the ED or no?
What do you mean, like if you're on
Your
rotations?
The tubing and stuff, once you go to the ED, you transfer care.
No.
Do you sign for that or no?
Okay. I
Okay.
mean, in the city,
So
they don't do that.
Okay.
Yeah, I think that's a purely Suffolk thing. Yeah.
Okay, yeah, I just want to make sure. So there's a physician who took out ET tube after the transfer of care. Is that common for physicians to do that or doctors to do that? And
No.
if so, should the paramedic document that the physician or doctor took it out after the transfer of care?
If they're aware of it, yeah, I would definitely I would have documented, like, you know, because it's also a matter on your own documentation where you're saying like the patient was tubed, we saw the vocal cords, we had condensation in the tube, we had equal chest rise, we had an end tidal of 35 with good waveform, and you usually attach that waveform to the ACR or the PCR. Upon arrival and transfer of care, physician extubated the patient. Like, there's no wrong reason to not, like, I would document that. But, but making sure
And
that you document that everything that you did was correct is more important.
Oh, thank you. Yeah, the paramedic did like recheck after to make sure when the patient was transferred from the home to the ambulance, and we checked everything, and what I think is a pretty good paramedic. He was just very upset that the doctor did that. I don't know why the doctor did it.
Yeah, that's often an ego issue, or the doctor doesn't understand what EMS does. That's usually the issue that I've encountered, is if they do that. Because a lot of the times what they'll do is they'll do the x-ray and they'll confirm that it's good, or they'll have a respiratory therapist go in and check the tube to make sure it's where it's supposed to be. They don't very often extubate a patient just for funsies. So that sounds like a doctor problem.
Got it. Thank you.
So, Nicole, I also put in the group chat a question. So, basically, can some of the reason for the spike in FCO2 be due to the body beginning to break down as far as cells and tissues? And when it comes to ROSC, like, is it, because it's however so many, what is it? It's like 2 to 4 minutes is tissue. I can't even remember cell death, and then I can't even remember.
It's brain. That's mostly brain. You'll have brain ischemia, and then after 6 minutes is brain death. So that your tissues are actually pretty good at surviving in low oxygen levels. They can, like, this is why organ donation works. They can survive for a period of time with minimal blood flow, but your brain cannot. So, like, the heart has, I think it's like 6 to 8 hours, like, muscle. So basically what you're getting is the muscles are, pretty much still producing carbon dioxide as they perform normal metabolic functions. So that's usually what that spike is.
Okay. So they're still trying to work, regardless of an actual circulatory system going.
Exactly. Yeah.
Gotcha.
Okay.
So it just leads to the buildup because your body's still functioning. It's just the rest of it that's not like, hey, let's go. Yeah,
it's still doing what it's supposed to do. Everybody else is like, hey, we got the memo that we're supposed to work, and the heart or the circulatory system is like, we're on break. So that's why you get that buildup. It's sort of like when you work out and you get lactic acid, and you're like, your muscles are sore.
Well, yeah, that's what I was thinking.
Yeah.
Something similar to that, as far as like the body still, okay.
Yeah, you're on the right path.
So then can you lead to, never mind. I just answered my own question in my head. We're good.
Okay.
Is that why bicarb is used?
Yes.
Gotcha.
It's also try to help alleviate the acidic nature that the body, so now, like, as the body continues its normal metabolic functions, it's still producing carbon dioxide from the lower levels of oxygen it has, and it also, once it switches to anaerobic, it still produces lactic acid. So now you have carbonic acid, lactic acid. The sodium bicarb comes and tries and sorts of neutralizes some of that acid to kind of help the body be less uninhabitable.
Gotcha.
Good question.
It's
Great question.
Trying to make it as close to equilibrium as possible, even though your body is unable to do it for itself.
Exactly. And epi is also highly acidic. So now you're throwing a little more acid in there, but your body can't function at high acid levels. So the sodium bicarb helps bring everything back where you have a better chance.
So because you always push epi, is it like the amount of bicarb that we actually use, is it a good amount comparatively to what, like, inside your body?
I honestly don't know.
Okay.
I don't know what, like, they have, it's supposed to be like 1 milli equivalent per kilogram. Usually they'll be like, give them an amp, which is 50 milliequivalents.
Gotcha.
So I don't know, and I'm not sure if they've done adequate studies on how much sodium bicarb is effective to bring you to an appropriate acid level. And it's also like you're not necessarily going to have the know what that patient's acidic acid level is prior to initiating.
Especially with depending on what their comorbidities are, they might be
how
used
long
to
they've been down. Yeah.
Exactly.
Okay, great question though. I'm gonna have to bicarb. I'm making a note. Hold on. Bicarb dosage.
Like dose appropriate to internal equilibrium.
Yeah. Again, it's going to definitely differ based on patient weight, patient comorbidities, and if they were how long they were down, stuff like that. But all right, cool.
If you have if you place a tube and it's in the right stem, are you able to leave it there, or do you have to pull it back?
You have to pull it back. Unless you have some sort of documentation that they don't have a left lung, you have to pull it back. And it's not far. It's like maybe a centimeter or so, like not even, to pull it back into the carina, right where the split is.
Okay.
So the mandibular, never mind.
Can you stop saying never mind and just ask the questions?
No, because I forgot the exact word. I saw it last night and I was like,
But it might help us. So.
All right. So where you bifurcate at the mandibular sternal notch, right?
At the carina, yeah. So that if you.
That's like where your carina is located.
Yeah. So like if you go down and that little notch, like between your clavicles.
Yeah. That's what I thought it was. I just wasn't
right about there. Yeah, that's where it bifurcates. Right.
That's pretty cool.
Yeah.
Which is equivalent to your T5, it said, right? So your trachea goes from your, what is it? The sternum. Well, the split is located there. Never mind. I'm mixing things up in my head. I did a lot of things late at last night.
But yes, you're around the T5, which is a lot higher than you'd think, is where a lot of the lungs and stuff are.
Is that why if you get say you get a spinal injury, it's so high up, that's when?
Well, no, that's based on just how your nerves are traced through your body. So like your brachial plexus comes out in very high, right? It comes out in your cervical spine, like C3, 4, 5, 6, but it's not coming out in one singular spinal space. It's coming out in multiple ones, and it's this huge bunch of nerves that kind of twine together and then run down your arm. So that if you have, say, an injury and the lower it is, the different location it is. So like if you have an injury at C6, that's where your ulnar nerve sort of comes out. So you'll have pinky and ring finger numbness and tingling. But if you have a higher, it's going to be higher up in your, so like C3 is going to cause shoulder numbness and tingling and all the way down the arm. So like yes and no. So like your body has created levels of duplication so that if you do injure one location, you could potentially still have some level of innervation. Just like when you in your heart, you have what's called collateral circulation. And we're going to talk about this in cardiology next module. But basically, you are giving blood to different parts of your heart via different vessels, just like in your head too, right? You have the circle of Willis, you have the front carotid, then you have arteries going up the back of your neck, and they meet in the circle of Willis. I always call it the circle of Bruce Willis because this is way more fun. That goes around the bottom of your brain and then creates blood flow into your brain as a whole. So if you have a blockage in one part of that circle, it can still get around and give you perfusion to that brain through another circuit, because your body just wants to survive. So it has a lot of these really cool duplications to kind of keep you from dying.
Yeah, I don't know. I feel like the nerves in the wrist are weird. Like how you said, your pinky and ring finger might go numb but that's a different nerve than the rest of your hand,
Mhm.
and it's all innervated. And there's like the 3 sets, right? It's like the radial something else and something else.
Radial, ulnar, and then you have brachials further up.
And it's all like a weird kind of just split. And it doesn't even make sense. I feel like it doesn't make sense. But depending on what you injured, you might be able to feel or not feel it in a certain spot.
Yeah, because you have different nerves that give you motor and different nerves that give you sensory too.
Yeah, there's sensory neurons and then
Mhm.
motor neurons.
The human body is pretty wild.
Oh, it's gorgeous. It's a beautiful, amazing thing. It's just, annoying at times.
Yeah, like we definitely didn't put everything together 100% well, but we tried. All right. Any other questions before we move on? All right, cool. So a number of things that can cause elevated end tidal in capnography is definitely metabolism, right? If you have any sort of reason that your body is going to burn more oxygen, right? If you have a high oxygen demand, so any sort of level of pain, hyperthermia, if you're shivering, right? Because shivering recruits a lot of muscles. If you have increased cardiac output with constant ventilation, right? So if you are exercising, you need to blow off that lactic acid, your end tidal will be higher, right? So if you're out go for a 10-mile run, your end tidal will be much higher than if you're sitting on the couch. Any sort of insufficiency with respiration, right? If you have obstructive lung disease, which we talked about, any sort of respiratory depression, right? Narcotics user, and sometimes you can have an equipment issue where you have like a defective exhalation valve that you're like, I don't understand. So let's go to this case study real quick. Dispatch to an unconscious male. He's found outside his vehicle, which is parked on the sidewalk. Friend states they were driving when the patient who was driving began to seize and lost control of the vehicle, so the friend threw the car into park. Patient has a pulse but is not breathing. Ventilations with the BVM are difficult, and during assessment, patient has a second seizure. As BLS goes to find more information about the patient, you prepare to intubate. Successful passage of the tube is visualized through the vocal cords. You get a reading of 100 on the end tidal. Ventilations continue to be difficult, and hyperventilation does not improve end tidal. What are your thoughts about this patient?
Hypoxic seizures.
Perfect. Absolutely. Hypoxic seizures.
Hours.
Sorry, that was my computer.
Okay. Why is he hypoxic?
So I would assume there's some sort of, constriction or like potential like blockage or something if you have difficulty with ventilation.
Exactly, right? You picked up on that clue, right? He's very difficult to ventilate. So that gives you a few different, obstructive issues, right? It could be a foreign body airway obstruction. It could be asthma. It could be COPD. He could have a tension pneumo, right? So these are all things that you want to consider. How else? Like, what would you do to determine what the patient's issue is? With lack of current history.
I would definitely get him out the car and to check his airway.
Mm-hmm.
You
Well,
do
you've
a
already
sugar
gotten tubed, so.
at AMS, you got to check for sugar. So do a sugar test.
Okay, sugars are adequate, 85.
Nicole, when you have someone tube and you just bagging them, you can still hear if they have wheezing or edema in there, no?
Yes, you can.
So you're gonna you're gonna monitor their cardiac output.
Okay, good. Blood pressure is 190/80.
What's his rate?
So,
Raw heart rate's 120.
would you see any frothy sputum coming up the tube?
Nope, no cough, no sputum.
Is he warm, diaphoretic at all?
He's warm, appropriate to environment, not diaphoretic.
Pale?
No.
How's the rate of the pulse?
Strong and bounding, heart rate of 120.
Pupils?
Equal reactive. Joni, you brought up a good point. You could about can you still hear? What do you want?
Yes. So what are the lung sounds?
You have diminished lung sounds by lat. You can barely hear his lung sounds.
So there's nothing.
Okay.
Is there any subcutaneous emphysema?
No subcutaneous emphysema. Good question.
Does anyone in the car know any information?
His friend, but BLS went to go get some more details while you're playing detective in the ambulance. Tension pneumo, okay, possibility. How would you further identify the tension pneumo? What would you expect?
I'll check for ribs if there's
Deviated trachea.
Okay, trachea. So
Won't hear
trachea is
anything.
midline. What else?
Decreased chest rise.
Decreased chest rise. All right.
We could also percuss.
Okay, you could percuss. Would you expect a patient who has a tension pneumo to be hypertensive?
Yes.
Mm.
No, but I would expect them to be tachycardic.
Okay, tachycardic, yes. So the problem with a tension pneumo is as the pleural space fills with air and starts to crush the lungs, it starts to move across to the unaffected side, which is why you get the tracheal deviation. The problem with as it moving across is it starts to crush the heart, so the heart can't expand or relax to adequately fill. So you wouldn't necessarily expect a patient to be hypertensive with a tension pneumo. Good thought though.
So hypotensive, tachycardic.
Yeah, what's the triad?
I forget the triad, honestly. I was just trying to.
You were 2/3 of the way there. Think it through.
No. Yeah, jugular vein distension.
Okay, good. Jugular vein distension. Hypotensive.
And tachycardic.
Yeah, with narrowing pulse pressure, right? So the number between the top and the bottom of your blood pressure get closer and closer together.
And what is it? 190/80?
Yep.
Could it be a hemothorax?
Could be a hemothorax. Absolutely, a good amount of blood in the chest would give you very hard to hear lung sounds.
Check his nares.
What you doing with his nares?
See if there's any powder in there. You never know.
I mean, from the murder.
Yeah, from the witness protection guy. His nares are good.
What? You can't hurt to take a look. He's hypertensive. He's now unresponsive. He's not breathing, but he does not have pinpoint pupils.
No.
He does have an active pulse. Well, yeah. So you never said, is there positive JVD? But he's laying down, so obviously there's going to be positive JVD.
There you go.
Sit his ass up and take a look. No, I'm just kidding. Well, not really.
Well,
take a look.
Well, let's now look at your end title.
It's over 100. So he's in acidosis.
Yes, he is acidotic.
I checked his blood sugar, and he's within range.
Okay, so he's not diabetic, ketoacidosis.
Fuck. So there's metabolic acidosis.
That is metabolic. He's in respiratory acidosis.
Respiratory acidosis. I was getting there. All right.
So have we addressed whether or not he has an airway obstruction? I know you have a tube in through the vocal cords, but I mean,
you have
it seems
adequate chest rise on both sides.
Okay.
There is there is no foreign body airway.
Okay.
APE?
APE?
Yeah.
EPA?
Maybe. If I told you this guy is 22 years old.
Oh, so then it's probably pneumo.
Maybe.
Is he athletic?
Heroin overdose.
Heroin overdose. No pinpoint pupils. There's no
Can you have a narcotic that doesn't affect the pupils as significantly as?
Yeah.
Yes.
It does.
Maybe he's up on Subutex or Suboxone.
Yeah. Okay. So what would you do for that?
Well, it already has naloxone in it, but I guess you would push more of it.
Yeah.
Give me, you know.
You can
More of what?
More naloxone. So Suboxone and Subutex both. Well, Suboxone has Jesus Christ, has naloxone in it. Subutex does not, and that's why you can still shoot up when you take Subutex. Fun fact at working in a rehab.
There you go.
Ooh.
The more you know.
There is no.
So you give this guy Narcan, and it has no response.
God damn it.
So would Mag do anything right now? So just because you're saying that he has diminished breath sounds, maybe Mag will just
Talk to me.
loosen up his
Keep
muscles.
go down this rabbit hole.
It would relax his muscles. So I'm assuming once he gets nice and relaxed, you can maybe hear wheezing, and if you do, then give him epi. Open up him a little more.
Do you have to wait to give him epi?
No.
No.
So give him epi straight away.
Okay. We're treating him as what though? What protocol are you treating him under? Because
I would probably go with asthma.
Perfect.
Okay.
Right? So now here's your clues for the asthma, right? He's difficult to ventilate with the BVM. Right?
So there's already pressure inside.
So he's already, right? He's constricted. He's got poor compliance, and his end tidal is 100. You have almost no lung sounds, right? So he's silent chest, essentially. So if BLS comes back to you and says, all right, so he's got an inhaler, he's been smoking, taking a hit of the inhaler, smoking a cigarette, taking a hit of an inhaler all day. Stupid. This guy put himself into respiratory failure more than once doing that.
Intubate his ass.
Oh, his ass got intubated multiple times. We brought him to Wyckoff, and they're like, him again? I'm like, really? You know this dude?
Oh, this call. Ah, damn it. Should have known.
Okay.
Good, though. A lot of you are already on the right track. This thinking is important. The way you're thinking is very good. All right, so on the other hand, when you have decreased end tidal, number one is definitely going to be like a potential perfusion issue, right? Cardiac arrest, pulmonary embolism, high shock state, anything, sudden hypovolemia, right? Maybe patients are severely dehydrated, secondary to sepsis or something to that effect, right? Go ahead.
Real quick. So decreased that CO2 means that there's a higher level of CO in your system. You're not able to get it out.
Mm-hmm.
Increased CO2 means that you're getting too much out, in essence.
All the way around.
Wait, what?
Increased CO2 means...
Yeah, as far as that CO2.
Yes, increased CO2 usually means that it's your body's making too much, and you aren't, but you're not also breathing it off. Either breathing it off effectively. Here, right? There's an issue with the lungs, or there's an issue with your too much circulation, right? The fast circulation, right? But this isn't too bad because this is usually considered like exercise states, right? So you're working out, you're creating a lot of lactic acid in your muscles, but you're also breathing adequately to get rid of it. From a medical point of view, either your body is creating way too much carbon dioxide, right? So your DKA, some sort of hyperthermia, where your body's, too much muscles, but you're not adequately blowing it off with your lungs, or there's some sort of obstructive issue in the lungs themselves, right? So asthma, COPD, etc. When you have a decreased end tidal, you are blowing off too fast, okay? Or there's an issue where you're either blowing it off too fast, or you're not actually seeing it, right? So if you have somebody who has got like severe mucus plugging, right, or a foreign body airway, right, you can tube somebody and you're like, fantastic, I'm in, and your end tidal's 3, and you're like, what? I don't understand, but you're also not getting good chest rise. It could be because there's a Lego in there, or there's a significant circulation issue, right? You have not enough circulation coming back. You can also have really low end tidal in severe sedation states and or hypovolemia, thermia, right? If your body's metabolism slows down super, super slow when you're really cold, right? That's why we can bring back, small children from the dead after we thaw them out. That's because their body's not using a lot of oxygen, which means it's not producing a lot of carbon dioxide. So those patients would also potentially have a very low end tidal. Does that make sense?
Yeah.
Okay. Also, when you're evaluating, if your tube is dislodged, or there's a hole in the pilot balloon, or you have a vent setting, like a vent patient, and there's a leak in that circuit somewhere, you'll end up with low end tidal as well. So if you have a high end tidal, it's your first thought should be that there's some sort of respiratory failure, right? The lungs are not working well. There's air trapping, or you're not breathing at all, right? But the perfusion is still good. The end tidal is low, the perfusion is not good, right? You're not getting the carbon dioxide back to the lungs, or you're excessively removing it, where you have a patient who's hyperventilating, okay, or a metabolic derangement where you're alkalytic instead of acidotic. So we talked about this a little bit. These are still on some ambulances, primarily in Nassau and Suffolk. It's a secondary device. This was the gold standard back before we had the technology that fixed that whole problem. Basically, you would ventilate the patient. If there was carbon dioxide when the patient was exhaling, it would turn yellow. It would be purple. It took at least 6 ventilations to appropriately interpret. So if you were ventilating and ventilating, trying to get it to turn yellow, and you were in the stomach, prepare for a vomit geyser. However, stomach acid was also would also cause the litmus paper to turn yellow, so you could potentially get a false reading. A number of different waveforms that you might see. If you want to go and look, this is a very helpful website that actually discusses each one of these. Some of them are not as pertinent to our practice as emergency, medical people. But this one right here, you have that shark fin, right? We already talked about that. This is what you see when you have a patient with air trapping. They don't have that nice square kind of vibe. They have this awkward looking shark fin. Means that they're not able to exhale appropriately. And here we are, the shark fin. Right, so instead of having that gradual plateau, you have this this very continuous exhale of carbon dioxide because they just cannot get out in the appropriate fashion. When we're talking about before, when you how can you tell if it is in fact a foreign body airway, you would get something that looks like this kind of peaked in, quick out. There's no gradual line like here. There's some sort of obstruction right here, and that causes this kind of mountain shape. If you forget to ventilate your patient who you now sedated and done a great job, you'll end up with this flat line, right? Because you're not going to have any oxygen in or oxygen out. This also can give you a good idea if the tube is dislodged or if you're in the esophagus, because the esophagus might give you a very low reading based on stomach acid. But if you have a really nice waveform and then all of a sudden you have a sad asystolic squiggle, you have most likely either stopped ventilating your patient or the tube is dislodged and you should recheck it. This is not something that you see very often, but it's usually if you have a patient who has a hypertrophic heart that you might be able to see the oscillations as they exhale, where the heart's kind of quivering and transmitting that movement to the lungs. So you'll get a weird squiggle pattern. Hold on, I need to curare cleft. This is the patient's taking spontaneous breaths over and above view, which means you need to like relax them again. You see this a lot in patients who are like in the ICU and intubated, and they maybe start what we call it bucking the tube. That you get this, they start to take their own inhalation, but then you kind of force them to exhale, kind of vibe. You won't see this hopefully very often because hopefully you've sedated your patient sufficiently. So where capnography is your vital sign for ventilation, pulse ox is your sign for oxygenation. And again, it's not 100% foolproof. Again, we talked about this a little bit last week. Non-invasive little device. You put it on a finger, you put it on an ear, sometimes you slap it on somebody's forehead, which is always fun. And it tells you how saturated the hemoglobin is with oxygen. The problem is you can have a lot of false positives, right? Carbon monoxide poisoning. There is a gas that is saturating hemoglobin, right? But it's not oxygen. So it will still read as a saturated hemoglobin, but it's not producing the desired effects. Patients who have anemia, when they have a lower number of red blood cells than they should, this also will potentially, they have red blood cells, they're 100%, saturated with oxygen, but there's only like 4 of them bouncing around, so it doesn't help the tissue perfusion at the other end. We talked about this already, right? You get the squiggles and it measures. Oxygen therapy is often very easy to kind of determine if it's effective or not based on the pulse ox. Some medications, right? You can determine if for example, you have a patient who's in rapid AFib, and you give them medication, you give them some cardizem to try to slow it down, and it improves their perfusion from 90/60 to 110/60, right? That pulse ox should show an improvement. Any sort of patient who you've given albuterol to, right, or steroids to help with their asthma attack, you should have an improvement in the pulse ox. The same thing goes for suctioning and ventilations, right? If you perform a procedure, you should be able to then check it with the pulse ox and or capnography to prove that what you've done was effective. It's just throw it on everybody. There you go. Pulse ox. Everyone gets a pulse ox. It's good to know. It helps guide your treatment plans one way or the other. And if you don't document it, there's going to be questions. People are going to be confused. Why didn't you do pulse ox, right? The patient had no fingers is potentially a good answer. But you should have the sticky ones too.
Put on an earlobe.
Yeah, an earlobe. Well, if you have the plastic one, it doesn't always work. So you have to maybe put it on a toe. So if you have a patient who's a quadruple amputee, I think is the only person who you're like, I couldn't do it.
Can the sticky ones work on the forehead too?
Yeah.
I've seen just put like the ones on like the goal of their finger and they just stick it on the forehead.
Yeah, that's only the sticky ones, obviously.
Okay.
But so not everybody has the sticky ones laying around. Those are ones that are usually liberated from a hospital somewhere.
And that's fun. Like I've never done that. That's fun on an adult. I've seen that done on like infants and stuff.
Yeah, they'll do it on like they very commonly do it on the elderly, especially in the hospital. Like you'll see like sometimes like they'll have a patient with the pulse ox sticker on their head because like so if you have a patient who's like really bad edema, like full body edema, and they can't get a good reading on the fingers because of the edema, they'll put it on the forehead because it's you don't really get an edematous forehead very often.
You also got cold hands.
Yep, cold hands, big problem.
Maynard's.
Yup.
Or another appendage you could stick it on.
Hey.
What?
Hey.
It would be Joni's.
Joni.
Oh, anyway. 3 different types of 3 different things that you just kind of need to know. You have your SaO2, your SpO2, and your PaO2. Your SpO2 is what we measure with a pulse ox, and SaO2 is the percentage of the hemoglobin that's saturated. This is when they take an ABG and they determine the actual number of So like if it's, because you do have some hemoglobin that might have carbon dioxide bound to it, that's still going to show up as a potentially positive on the SpO2. If you have a patient who's a carbon monoxide patient, even smokers, right? Smokers carry carbon monoxide in their systems due to their smoking habit. So if you do an SaO2, it's going to show potentially a hugely different number than your SpO2. And then you also have your PaO2, which is the partial pressure of the oxygen dissolved in blood. Again, this is measured by your blood gas, your ABG. This is where we live. We live here in the middle, SpO2. 95 to 100% is considered your normal value for a healthy patient. Some patients might live in the 93 to 97%, right? So COPD patients. If you have any reading below 90, you should very well be putting that patient on oxygen. If you have a patient who is complaining of shortness of breath, you should be putting them on oxygen, okay? If you have a COPD patient who calls for something unrelated, right? They have like a broken foot and they're on normal home oxygen, you can maintain them on their normal oxygen. You don't have to throw them on a non-rebreather, okay? Just kind of use your noggin for that one.
Yeah, one of my paramedic partners says you got to treat the patient, not the machine.
Exactly, and you're gonna hear that a lot as you go through this class. Treat your patient, not the machine, because you can have patients who have bizarre-looking cardiac rhythms who are just chilling. They have no chest pain. They called for, again, like a broken foot. Are you gonna start treating their cardiac problem? Nah. I think we discussed most of these limitations already. So just keep those in mind. Like pulse oximetry is helpful, but it does have a certain level of limitation.
You can also get oxygen. Sorry, Nicole. You can also get oxygen with someone seizing.
Yes.
Like,
yeah. You might not be able to get the pulse ox to stay on their finger, but you should 100% be giving that patient oxygen.
I have a question.
Yes.
We had this ALS patient not too long ago, and he kept saying that he wanted to refuse oxygen, even though he was like saturating like in the very low 80s. And he's like, I can't have oxygen. Like it's bad for me because my doctor said I can't have it, period. And like he just refused. He didn't want to have it. So during the transport, it started getting worse. And when we finally got to the hospital, he kind of was like, I want oxygen. And then, we gave it to him, and like his oxygen like went maybe like to the low 90s. My thing is, in that case, like I get why he's saying like, oh, ALS patients don't need shouldn't have oxygen because like it can actually like suppress like the oxygen drive and all that. But in that case, like what could we have done? I mean, we listened to what he said. He said he didn't want it. So like,
yeah.
But now he starts decompensating during the rides. Like
the only thing is to continually just like, hey, you look like you're having a hard time breathing. Can I give you some oxygen? Or how about I give you like a non-rebreather mask and you can hold it a little, like a blow-by kind of situation, and like let him dictate how much oxygen he's getting. But it sounds like he got just bad advice from his doctor, who like then they get that idea set in their head, like I can't do it. I have to do this, that, the other thing. You did honestly. I don't think that there would be much else that you could do to kind of just basically just have to convince the patient, especially as ANO3. Like,
yeah, he was not having it. He's like, my doctor said, like, I cannot have oxygen. I will die. So we were all like, okay, like, but you're gonna die anyways.
Yeah. Would you rather die while you can breathe or you can't breathe?
Yeah. So like, I was just curious as to on a call like that. So now, like, say he gets, AMS and he just starts to decompensate, and then we end up tubing an ALS patient. It kind of looks like kind of effed up in my mind.
Yeah.
Like if he really went down the drain.
Yeah, no, if he went down the drain, like that's not your fault. You did everything that you could have done, to tell him like, hey, like you will die if you don't, have this oxygen. And he's like, no, he's ANO3. You can't force him to listen to you
until it's implied.
until he dies, and then you imply.
10-4.
That he was oxygen, and then like he did get supplemental oxygen at home, and then his doctor like weaned him off. And
No, he's near death. Like he's really decompensating pretty fast. So he goes to the hospital like all the time. We've taken him a few times, and this particular time, like we put the pulse ox on. We're like you're at like low 80s, and you're struggling to breathe right now. And he's like, no, my doctor said that I need to go to Manhasset, and they have a special machine there. And we were like, well, what are you talking about? And he's like, oh, BiPAP. And we're like, okay, but like in the meantime, let's put you on like a nasal, maybe non-rebreather. He was like, no, it's going to kill me. So we're like, okay. And then during the ride, he also loves to talk and like explain everything that's going on. So that's just making it worse. So he was like dropping down like into like the low like 79, 82. And then when we got to the hospital, the nurse, like we told her, but they don't listen. And then she was like, oh my God, he's like in the low 80s. And we're like, yeah, and that he doesn't want oxygen. And finally he was like, okay, you know what, I'm gonna take it because I feel like I'm gonna die. And we were like, okay. So we gave him like nasal. By that time we were in the hospital, and I asked him, I was like, is it because you've had oxygen before? He's like, no, it's just my doctor specifically said that I can't have it. And I'm like, this is kind of backwards. So
yeah, that's
weird experience.
silly.
White people.
Oh.
I'm just document everything.
Exactly. As long as you document, you're more than ahead of the game. But yeah, so pulse ox. But see, that's the thing is like, so if you had blow by, you could have potentially even gotten a better idea of how poorly this gentleman was doing, because you kind of put the two together. So it might have been like that. There's also a circulatory issue or a like a obstructive issue, right? If he had COPD or something else. So commonly putting the two together is most helpful. It's not, if you don't have the appropriate equipment, like the side stream, it can be a little more complicated to actually achieve that though. All right, so we're going to revisit this case study again, and we're going to see if you guys remember anything I just talked about. You have an obtunded female and respiratory failure, and you have no way to get information due to the patient's status. 90% on room air, 94% on non-rebreather. All lung sounds are clear. You decide to intubate. You see the tube pass. You get equal, adequate chest rise and easy ventilation, but the end tidal registers at 20. What do you think is going on?
Person's refusing oxygen.
She's not refusing. She already did, or in failure.
Metabolic.
Metabolic what?
Alkalosis.
Alkalosis. Okay.
She needs sodium bicarbonate.
Bicarb's more for your acid side. She's alkalytic. Sodium bicarb's not going to help her as much.
Can you try and hyperventilate her, as Joni said earlier?
Do you want to hyperventilate or hypoventilate this patient?
It's reading 20.
Hypo.
Because they're already breathing too quickly.
Yes.
Because they're putting everything off already. Hypo.
Okay.
I thought sodium bicarb would increase the CO2. Oh.
It's gonna bind to the carbonic acid and make it water.
Is this hypokalemia?
Okay, could be a severe electrolyte imbalance. It's causing alkalosis.
All right, do a blood sugar on her.
Okay, it's 80.
God damn it.
Do we already throw a monitor on her? Let's see.
You did not.
So let's throw a monitor on her.
She said sinus tachycardia.
Oh, awesome.
Cool.
So it's a circulation issue.
Okay. Where is the circulation issue?
Cardiac.
Okay. How would you confirm that?
With the monitor.
Okay, but the monitor gives you an electrical image of the heart. How are you going to figure out the mechanical part of the heart?
Millicent issue.
Does she have any kind of edema?
No edema.
What kind of medication is she on?
Hold on. We're going to go back real quick before I give you medications. How are you going to determine what the mechanical function of the heart is?
I said, we can listen to her heart.
You can listen to her heart. What else you going to listen to? Or listen for?
No.
The lungs.
All right,
You
your
said-
lung sounds are clear. But is that helping you with the mechanical function of her heart?
No.
No.
What's the basic vital sign that will give you an indication of the
blood pressure.
mechanical? Thank you.
Pulse.
Ah.
Crying.
Her blood pressure is 130/80.
That's fine.
That's
okay,
good.
So what's her pulse?
She is on. She is 34 years old. She is on birth control and a multivitamin.
Oh, it's the birth control.
That's her first mistake.
Damn.
It was that Flintstones vitamin.
It's the no. Well, the iron combination with her birth control probably created a clot. Is she a smoker?
Yes.
She taking antibiotics or anything? Like, what's she doing?
No, she totally has a clot.
But where is her clot? Pero, where is her clot?
It probably a pulmonary.
Thank you.
That's how that girl died in the airplane, actually.
Yep.
Yeah, get pregnant. Shit. No, I'm just kidding. We don't need more children in this world.
Yeah. She threw a clot just like that when boarding the plane.
Yeah.
And that's crazy. Stuff is no good for you.
Well, that was beautiful.
So it was a combination of birth control and vitamin that
It
produced
was
the clot.
Captain of Flintstones.
You know nothing about birth control, George. Joni.
Yes, I do. Now I do. Now I do.
Those Flintstones.
17 children and counting.
All right. Any questions? Let's check this chat real quick. Pulse BP, yes, thank you. All right. Any questions before we do CPAP?
No, I just wish I had an 8. Oh, I do have an AC. Am I speaking still? Oh,
You are
my
still
bad.
speaking. Hi. All right. Here we go. CPAP. Come on. There we go. So I like to say CPAP is like the duct tape of respiratory solutions. They've changed the protocol, so pretty much anyone who's having serious respiratory issues, respiratory distress, you can put on a CPAP regardless of whether or not they have fluid in their lungs. The idea is that it will open the lungs through that extra pressure and keep them open so that gas exchange can occur. Regular respiration is a negative pressure driven situation, right? So as the diaphragm over here, you see the diaphragm moves down, the intercostal muscles contract, which moves the ribs up and makes a bigger space inside of your chest, which makes air rush in. As all those muscles relax, it makes the chest cavity smaller and it pushes air out. Okay. You can force air out, right? You can kind of bear down and push air out, as well as you can kind of expand your chest a little extra in order to get a little bit more air. Your alveoli are the functional portion of your lungs, right? They're like these little cute grape vibes at the end of each bronchiole. They're very, very thin, right? You have one layer of epithelial that makes up an alveoli, and you have one layer of epithelial cells that makes up a capillary, right? So that oxygen and carbon dioxide only has to pass through 2 cells, right? It's very thin. Gas exchange is usually very easy. Atelectasis is or is caused when the surfactant kind of is either washed away or there's insufficient inspiration to keep the alveoli open. Drowning and stuff like that can wash away surfactant, causes the alveoli to collapse upon themselves and get sticky, and like you just reduce the amount of surface area that you have for air exchange. Quick review, right? So ventilation is the movement of air in and out of the lungs, whereas respiration is the actual exchange of gas. So you can ventilate a dead body, they will never have respiration. Respiration is when that gas is exchanged between, in the external situation, is between the capillaries in the lungs and the alveoli. And internal respiration is between red blood cells and the cells in the body, right? So deep inside your body, all those tissues that need oxygen, that's your internal respiration. We commonly inhale about 500 milliliters of air. About 30% of that lives within dead space and never sees an alveoli. But mind you that the adult BVM, depending on your manufacturer, is anywhere from 1,200 to 1,600 milliliters of air. You don't need to go crazy, just enough for chest rise, right? Back to EMT school there. Your inspiratory reserve volume is the maximum amount of air that you could take into your lungs over and above your normal tidal volume. Excuse me. The functional residual capacity is what is left inside your lungs after you exhale, right? Because not all of that oxygen comes out, right? Ever since you take that first really big deep breath as a baby when you're born, there's always a little bit of air in your lungs. Unless, of course, you're like run over by a steamroller, in which case you have some Looney Tunes problems, but you're not going to have that air in there. Usually there's about 1,200 milliliters of oxygen left inside your lungs. This helps prevent atelectasis, keeps them open, and keeps your chest kind of chest-shaped. Number of different respiratory issues, right? So respiratory distress is like someone who just says, I can't breathe, right? I'm having a difficult time breathing. I feel short of breath. You can have anywhere from someone who's like still able to speak in full sentences all the way up to someone who literally cannot breathe, right? They can't speak at all, or one to two word sentences, and they're gasping. A number of different things can cause this, right? We've all, I think, have some level of experience with this, where you can have someone who might have a foreign body airway obstruction, to impaired muscle function, or pneumonia or bronchitis, right? So this is like your kind of run-of-the-mill, you give the patient oxygen, you try to find out what's the cause and treat that. When you get to a certain point where after severe respiratory distress, you can go into what's considered respiratory failure. A respiratory failure is the point, right? This is when you walk in, you're going, this patient's probably going to need to be tubed, right? They are lethargic, they're very sleepy. They're doing the head bobbing, their altered mental status. It can be caused by an issue with the lungs, or issue with the heart, or a combination of the two, okay? Right, so if you have somebody who's got CHF up to their eyeballs, it could be, it's a cardiac reason that they can't breathe. Their lungs are healthy and in good shape, except for the fluid that's hanging out inside them. And we talked a little bit about all of this already, right? The signs and symptoms of what you're going to look for when you have a patient who's in respiratory failure, right? The cyanosis, the mottling. They could start off where they're breathing really fast, and then they kind of slow down because they're starting to get tired. Heart failure is pretty prevalent. Once you have one side of the heart that is failing, the other side of the heart generally follows suit, okay? It's very uncommon to have a one-sided heart failure. It might, persist for a period of time, and if it's not like fixed or managed, the other side of the heart will will follow suit. When you're thinking about lung or heart failure, you need to think about from whence that blood came. Okay, so right-sided heart failure, you'll have fluid buildup in the feet, right? Because that if the right side isn't pumping effectively, that blood will back up, and it will back up from where it came, which was the systemic circulation. If you have left-sided heart failure, that blood was coming from the lungs, and if it can't be pushed forward into the body system, it's going to back up into the lungs. So this is where you get that CHF, right? This is left-sided heart failure. It's a very common symptom. Most of the time, there's a lot of different reasons that can cause heart failure. It could be a loss of myocardial tissue secondary to like an MI, or some sort of other like infection, right? It could have myocarditis, pericarditis, issues like that. You can have volume overload, right? Dialysis patients who miss a treatment might present with a certain level of what looks like heart failure. Anything that might impair the heart from beating effectively, right? The tension pneumo kind of will mimic what you would expect to also see in heart failure. Heart failure is very dependent also on gravity. So if you have a patient who sits all day, and if they have right-sided heart failure where it's backing up into the systemic circulation, they're going to have, fluid that's in their legs or in their hips. If you have a patient who lays down all day, they'll have their edema might be in their lower back or in their hips and their sides or stuff, depending on what side they're laying on. When you have left-sided heart failure, those patients are going to have a very difficult time laying down, right? So if you think about your lungs like kind of like a cup, right? Like a sippy cup, right? It's got a top on it. If you stand that sippy cup up, it's only covering a little bit of water, and the bottom is only going to cover the bottom part. If you put that sippy cup on its side, you're going to have a wider spread of area that's covered by the water that's in the cup. That's sort of the same thing that happens when you lay a heart failure patient down if they have a lot of fluid in their lungs. You go from, where it's managed at the bases to where it's covering the entire lung itself, and it reduces the amount of surface area that is available for oxygen exchange. Pulmonary edema is usually a very acute emergency, okay? Like this is in discussing acute pulmonary edema, not, ongoing issues. What happens is there's usually a cardiac issue, right? There's some sort of cardiac concern. Maybe there's a sudden damage to, what's up?
I'm sorry.
Okay.
So somebody who has TB, right? How they have the frothy pink sputum that they spit up. Is this the surfactant?
That's actually the nodules. The TB
Yeah.
grows in like a nodule in the lungs, and then it kind of hijacks the blood supply in the lung, and that's from the coughing. That's where that frothy pink sputum is. In acute pulmonary edema, that fluid, right, that even, CHF patients will have a similar issue, right, where that fluid starts to build up in the alveoli, and then they start to cough, and it bursts some of those capillaries, right? Because remember, it's two cells. It's two cells from the alveoli to the capillary. Once that alveoli collapses, that capillary is susceptible to bursting. So as the patient tries to cough and clear their airway, or to kind of reopen, right? As you cough, you're increasing intrathoracic pressure, so you can hopefully reopen some of the alveoli. Same thing with like when you take a deep breath or you sigh. It's all, to try to reopen your alveoli. As is yawning, excuse me. So basically what happens is the fluid starts to back up because the heart's not doing what it's supposed to do. And as it backs up, the fluid builds up, and it's usually very quick onset. And CPAP is fantastic for this. You won't necessarily see the frothy pink sputum as much in APE. It depends on how violently the patient is coughing, and how bad the fluid buildup is. But it is commonly, you'll just get just regular frothy sputum. It isn't always necessarily pink, but for test purposes, frothy pink sputum is sort of like the key acute pulmonary edema clue. I think we've talked about asthma pretty thoroughly so far, but it is a reactive airway disorder, right? And it's twofold. So the first problem is when the smooth muscles of the bronchioles start to constrict, right? So something irritates them and they can start to clamp down, which makes the airways smaller, right? This is why we give albuterol, because it's a beta agonist and it comes in and it stimulates the beta receptors along the bronchioles to help dilate everything. The second problem is that there's all sorts of what's the word I'm looking for? There's goblet cells inside the bronchioles, and they start to release mucus as a protective measure because your body thinks it's under attack. As they start to release mucus, you have the second wave of the asthma attack, which is just increased levels of like just junky goo inside the lungs, right? So that's how you the patient starts to cough a lot, right? So this is why when we treat an asthma attack as ALS providers, we start off with the albuterol, the ipratropium, which works similarly, where as opposed to it shuts, it's a parasympathetic antagonist, so it shuts down that constriction caused by the parasympathetic side. And then you could also give MAG, right? We've talked about the MAG a little bit before, right? Because that also relaxes smooth muscles. And you also can give the steroids. The steroids, when they're in the body, what they do is they stabilize those goblet cells so that they don't release mucus. So while the patient's sitting in the ER is feeling a little bit better, now you've prevented this second wave of mucus that's going to cause like a secondary asthma attack, okay? So this is why, we just like a 1-2 punch for treating asthma. COPD is a triad of different diseases, right? So you have I think the most commonly considered COPD is emphysema, right? It's, you have these really expanded alveoli that lose their elasticity, which means you have reduced surface area for the capillaries to exchange oxygen and carbon dioxide. The patient no longer breathes based on low oxygen levels and starts to breathe on the hypoxic drive when the carbon dioxide gets too high in the system. Asthma, if it's like a long chronic asthma, this patient can be considered to be a COPD patient. And chronic bronchitis, which is a little bit of a different mechanism than asthma and emphysema, where you have the alveoli and the muscles that are causing a lot of the issues in asthma and then COPD, where the alveoli are just getting kind of like overinflated. Chronic bronchitis is just an excessive mucus production, okay? It doesn't really affect the alveoli. It's all of the bronchioles and stuff, just all those goblet cells are just like, hey, I'm feeling really frisky today. I'm gonna produce a little too much mucus, right? And that mucus is considered chronic bronchitis because it's also just like a level of inflammation. That mucus is also a really good habitat for bacteria, so you can have like just chronic infections. Patients have a hard time breathing through this, so they end up kind of hypoventilating in order to kind of deal with the level of inflammation because it's just a smaller airway. And then again, they end up with the hypoxic drive, as you see in patients with emphysema. But your diffusion is still pretty decent in terms of like the alveoli aren't, overinflated, or they're not, damaged in any way, shape, or form. It's just that the passageways to the alveoli are blocked. Kind of touched on this already, right? So your normal alveoli look like little grapes. When they get overexpanded, they lose a lot of this extra surface area, right? So if you consider this spot right here, these like there's capillaries covering all of this. If that's not there, there's just less area for the gas exchange to occur. Patients who have COPD often present with what we consider called barrel chest, because they have air that's trapped in there because this is not elastic enough to push air out of the lungs. Another problem with emphysema is the formation of blebs. So as these giant alveoli start to become weak, they'll push out, and it's very very common that they'll burst, right? So you have COPD patients are at a high risk for pneumothorax, okay? CPAP might make it worse based on, like, you know, the fact that there's a weak spot and you're putting it under extreme pressure. The problem with that is that it's very difficult for you to know if the patient has a bleb. So this is, again, where close monitoring of your patient and constant reassessment is important, because if you have a patient who's got a hard time breathing because of COPD, you put them on CPAP and all of a sudden they get worse, you might want to take them off, right? Because now you might need to decompress them. The two different, this is usually, like, they love to put this in the textbooks, of the difference between chronic bronchitis and emphysema, or is your blue bloater versus your pink puffer. It's very infrequent that you see a person who has just one and not both. It kind of overlaps so dramatically now because people are just abusive to themselves in terms of, like, smoking and other damaging lung issues. The sad part is you can actually get emphysema even if you have never been a smoker. Like, your body's just like, that's been cool, but I just don't really like this alveoli here. The blue bloaters, right? They'll often have a kind of a gray look to them because they're not exchanging they're not exchanging oxygen quite as well due to the mucus, where they always have oxygen in their lungs. It's just not the same exchange that you would expect. So that brings us to CPAP.
Quick question.
Sure.
While we're on respiratory. Oh, whoops, wrong thing. So I should say, when it comes to, like, somebody, like, as you brought up earlier, that kid that, you know, was taking the inhaler, taking a hit, taking an inhaler, taking a hit, taking an inhaler, taking a hit.
Mm-hmm.
So you eventually you push your body to a point where now it's not able to combat whatever type of spasm. It's just gonna freeze up on you, right?
Say that again.
All right, yeah, that didn't really make sense. Okay. So you're using a bronchial dilator, right?
Mm-hmm.
And you're having something that is naturally, you know, smoking, that is
Mm-hmm.
naturally going to make your body want to constrict because it's an irritant.
Mm-hmm.
And you're going to have an inflammatory response, but you keep using something to combat that,
Mm-hmm.
and eventually it's just not going to work anymore.
Yes.
So you could went into respiratory rest. And like any other drug, you build tolerance, et cetera, et cetera. When you abuse something, you tend to lead to a point where now you have rebound effects, right? So
Yes.
like you have bodybuilders that use nasal sprays, and now they have chronic runny noses. So then they have to continue. So now say somebody who's a chronic recreational pot smoker, right? So it has all of its positive medical benefits,
Mm-hmm.
you know, decrease in intraocular pressure for patients with glaucoma. It has a natural bronchial dilator within it, but due to the fact that you're smoking it, most people that do smoke it, it tends to kind of combat that in and of itself because it's smoke inhalation, and then you have the resin or the tar buildup in the lungs that tend to be thicker than that of actual
Nicotine.
cigarettes. Yeah, exactly. Can that, like, if you're a long-term user, can you then lead into a rebound effect?
Most likely, yes.
Now your body
Asking for a
naturally,
friend?
yeah. No, I don't fucking smoke pot. It shit makes me way too anxious. And I get blood drug tested. There's no, you know.
Yes. No, that almost anything can cause a rebound effect after a certain amount of time. Like, there's just, you know, you see it with antihypertensive medications. You see it kind of across the board. Yes. So I guess, like, the short answer is yes.
Okay.
Any other questions before I continue? All right, cool. So a study in 2008 actually found that pre-hospital CPAP reduced the need for intubation by about 30% and reduced patient mortality by about 20%. It's very effective. And yes, there are definitely some patients who either A, cannot tolerate it, or B, really do need to be intubated. But those are really significant numbers in the medical community. It's highly effective when it comes to non-invasive management of a lot of different respiratory issues. So basically what happens is you put this mask on the patient. She's like super calm. You put this mask on the patient and it just blows oxygen into the lungs, and it keeps everything open regardless of what stage of the respiratory cycle you're in. Okay. If you see this CPAP in particular also has an inline nebulizer. You do need a secondary oxygen source in order to aerosolize whatever you are nebulizing into the CPAP-y life. You can also see here they have her on the side stream. Okay. While it's a really good setup, it can cause some complications in terms of mask seal. So just something to keep in mind. It's super helpful to help monitor your patient if you are able to rig it up and or have that side stream available to yourself. BiPAP is 2 levels.
Where would you
Go
side
ahead.
stream in something like this?
Say it again.
Where would you put the side stream?
You broke up. Say it again.
Where would you put the side stream in something like this?
The side stream would go in their nasal, like it's the nasal cannula, so you would put it like the nasal cannula setup.
Oh, I mean so you have,
The
yes, so
inline.
the side stream is what she has, yes, the inline. How would you set up the inline?
You could potentially put it right in between the mask and the this part, the valve.
Them?
You're not going to necessarily get you'll get an okay reading, but it's not necessarily going to be super accurate because it's going to be significantly diluted by the amount of oxygen that's kind of blowing through.
Gotcha.
So the closer to the patient, the better. I have done it, like I have done the setup that you're talking about, and it gives you a little bit of a reading, but your waveform is going to be kind of crap. So CPAP increases the functional residual capacity, right? We talked about that, about 1,200 milliliters of oxygen that's always inside your lungs no matter what. So what it does is it increases how much is always inside your lungs. So you might be moving a little bit of oxygen, but you know, in and out on a regular basis, but your inside oxygen is always is a lot higher. It reduces the space between the capillary, right? So if you look at this is a representation of what the capillaries are. It reduces the space between the capillaries and the alveoli. So if you have a patient who's in acute pulmonary edema, it's going to push this alveoli open more, and then it's closer to it gets the fluid out, and the capillaries are up close to each other, so that oxygen diffusion can happen better. It reduces the work of breathing because now your chest is full of air. Like there's no way you can have a difficult time breathing. Concurrent or subsequently, when it does that, it also helps reduce patients' vital signs into a more normal range. So you have a patient who might be struggling to breathe and they're highly tachycardic and they're extremely hypertensive because they're trying really hard to stay alive. You put them on CPAP and give it like 5-10 minutes, their vital signs will start to come back down to where they should be. It takes a lot of the extra work out of breathing, so patients' oxygen demand is lower because they don't have to work as hard to use the muscles to get the oxygen into their lungs. It also overcomes atelectasis, right? So if you're pushing all this air, those like any alveoli that may have collapsed are going to be forced open and then kind of reunited with the capillaries that they may have been missing. And it just works really well. It also, any sort of like edema that is inside the lungs, it pushes it back into the capillaries and redistributes it back into the vascular space. Really, really effective. Kind of wild how good it is. It can be used for almost any respiratory disorder if the patient is awake, alert, and doesn't fall into any of the contraindication categories. Like I wouldn't put it in a patient who's got an open chest wound. You're going to cause an issue. If your patient is not completely altered, it's not going to work. Accessory muscle use, persistent hypoxia, even if you're aggressive. And aggressive with oxygen therapy can be assisted ventilations. It could be a non-rebreather. Again, you need to kind of look at the patient and make a clinical judgment call here. You can put a patient on a non-rebreather and their SpO2 has gone up, but they're still like really struggling to breathe. You might need to, adjust accordingly. You might have a patient who's on a non-rebreather and their pulse ox hasn't gone up at all, but they look like they're having a little bit of a better time breathing. you don't necessarily put that patient on CPAP because maybe it's not a lung issue, maybe it's a blood issue, right? Maybe they don't have enough red blood cells or something like that. So another number of indications. I think we've covered a number of the contraindications that would cause issues. If a patient's severely hypoxic, that extra intrathoracic pressure is not going to help their blood pressure go up, right? You're just going to put too much pressure around the heart where it's not going to be able to refill effectively. If they are breathing too slowly, right? That's a sign more that they're going into respiratory failure, and you're going to have to be more aggressive with your airway management. Active nausea and vomiting, like you don't want like a CPAP mask full of vomit. That's just going to end poorly. But you can fix this potentially, right? So if you give a patient Zofran and they're like, I feel so much better, I'm not nauseous anymore, you can potentially now still apply the CPAP and help whatever the respiratory issue is. Any sort of tracheal lung surgery, right? You don't want to put too much pressure on a potentially weak area. A lot of patients, the claustrophobia is the biggest issue. They have a hard time managing with this mask. It's kind of cumbersome. It covers most of their face. It can make them really anxious. It's just kind of wild. It is also not a mechanical ventilator, right? It's just pushing air in. The patient still needs to participate, which is part of the reason why it's better than intubation, because the patient still needs to participate. They still need to activate their respiratory muscles, whereas in intubation, you're taking over all of that. You also need to make sure that you have adequate oxygen, right? This is usually the call you get when you just got back to the truck and you look at your portable O2 and you're like, it's close. It's like 900 psi. We're good. And then you get this patient. You're like, damn it, I should have changed that oxygen tank. Almost without fail. So, any questions? Darius, all I saw were your feet for a second, and I was really confused as to what was going on. And I was like, is he okay? Questions, thoughts, concerns? Let me see what's in the chat. Chatting about chronic smoker questions. All right, I think you asked that, right?
Yes.
Okay. Seriously though, any questions? Do a couple math questions with y'all. Hold on, just pulling up. Did you guys watch the videos that I made of the drug math review? Was it helpful? You're allowed to say that no?
Yes, they were.
Yes, that's helpful.
Okay. See if I can find some more questions and I'll make another review video for you guys.
We used to work with this one Losartan medication that for cardiac, I think. That I was very confused about.
Do you happen to have it?
Hold on.
Y'all look way more comfy than me.
Taking a nap after this.
Jelly. They're shooting up like fireworks around my house, so my poor dog was hyperventilating all night because he was not about that life. He was having like PTSD flashbacks.
Yeah.
Rob, you're laying in bed like like a high school girl on the phone, bro.
Exactly what I was thinking.
His feet waving like he's in a giddy conversation.
I'm comfortable.
And did you find the question?
Still downloading. Hold on.
Jesus. I need somebody to play the Jeopardy music.
Question. Ooh.
Wow, feedback. What's up?
Okay. What?
You have two devices open apparently.
If I leave one, will I get locked out?
I don't think so.
Right. She cheating. Why she got two open?
I don't know. There's only one on mute.
She's trying to get double credit or something.
You're muted. So.
Can't hear you, Soraya.
Oh, yeah. I was trying to figure out how to like go from the laptop to the phone because I'm trying to leave the house and I needed help.
What's your question?
No, that was the question.
I'm muting you. All right. Andrew, what you got?
Sorry, hold on, stand by.
The suspense is killing me. All right, you look for
I
that.
got a question on the is it CPAP? Well, more, yeah, I guess CPAP and intubation, because you see how when you're giving oxygen through nasal, right? You want to humidify it if you're like on traveling long distances.
It's preferred.
Yeah, so that way he doesn't irritate it. Would intubation or even CPAP irritate going down?
Oh yeah.
And then maybe cause some adverse effects.
In the hospital long term, they very commonly will humidify the oxygen for a tube patient through the vent system, the circuit. When you have a patient who's on CPAP, I don't think that they very commonly whatchamacallit, they don't humidify it because you're still producing some level of your own humidification because it's still going through the normal pathways. It's not bypassing like all the way down, so it's a little less irritating.
Gotcha. What about intubation? Like for example, these COVID patients that have been intubated. Is there such a thing to humidify it on the well, 'cause since it's all the way down, it's not going through the upper area mucus.
I mean, you could potentially humidify it with like a nebulizer and whatchamacallit, a nebulizer and some like saline. You could put that in line, but you need a secondary oxygen source to aerosolize the saline.
Cool, thank you.
That's on the question. I put it in the chat.
Okay. Well, I need a post-it note to write it down. 0.01 mg per kg of epi to an 11-pound child in cardiac arrest. All right, so let me move over to the whatchamacallit. Go away. I want to share my screen, jerk. All right. So, if you have the desired dose is 0.01 mgs per kg, and you have an 11-pound patient. First things first, you want to determine how many kilos this patient is, right? So 2.2 pounds, right? Or there's, you know what I mean. I'm having a brain fart. So 22 goes into 11, or it goes into 1, 0. 22 goes into 11. 0 times 22 goes into 110. Y'all.
8 times.
6.
8's too much.
5.
Thank you. 5, right? So, right? 5 times 2 is 10. 5 times 2 is 10, plus 1 is 11. So you have a 5 kilogram patient. So 0.01 times 5. You're going to move your decimal point over twice. 1, 2. So you're going to give your patient 0.05 milligrams of epi. Is that the question? Or does it ask how many milliliters?
Why is it 0.05?
No, yeah, that's the correct answer, Nicole. It's just, it doesn't say milligrams, it just says decimals.
Brianna, it's 0.05 because when you have your decimal point, so you have there's 2 places after the decimal point. When after you multiply it, you just move the decimal point over twice.
Okay, sorry.
That's okay. So that's the correct answer, Andrew?
Yes, that's the correct answer, but we didn't have to do milligrams. You just put the numbers.
Yes. Yes, correct. All right. So let's do
Thank you.
You're welcome. So let's do a quick dopamine question. All right. You have a 220-pound patient. You have to give them 5 mics per kilo per minute. And you have 400 milligrams in a 250 bag. All right. So first things first, you're going to convert this to kilos. How many kilograms does a 220-pound patient weigh?
100.
Perfect. You're going to multiply that by your desired dose. Okay, this is your desired dose. Now, you're going to calculate your dose on hand, right? So it's going to be 400 milligrams in a 250 milliliter bag. Off the top of your head, what's your concentration? Nope, still didn't memorize.
Is it 25?
No. What's your concentration if you put 200 and 250?
300.
Okay, so you double how much. You doubled how much medication you're putting in the same size bag. What's your concentration?
Nicole, you put 24, is it 25?
Yes, it is. Thank you.
$16 equal $4, right?
Most days, yes. So let's put it into the equation, right? It's desired dose over dose on hand times your drip set. So your desired dose is 500. Dose on hand is 1600. What drip set am I going to use?
60.
Good. So we're going to make this a little easier to work with. 5 times 60.
300.
How many times 16 go into 30?
Once.
How about into 140?
Eight.
Okay. How about into 120?
7.
How about into 80?
5.
That's your drip rate. All right, let's try another one. You have a, let's see, hold on, 154-pound patient. Your order.
Nicole, sorry, I also put another question up as well.
Okay, thank you.
It's in a group.
Okay. All right. First things first, let's find out our desired dose. Convert your pounds. How many kilos?
72.
See, we're close. Just 70. You're gonna multiply that by 6. Anybody?
$420.
Now, what's your concentration? Y'all, we just did this the last question.
1600.
Thank you. So plug it in. 420 over 1600 times your drip set. Let's make this a little easier. $42 times 60. Okay, simplify it. I'm not going to do the long division.
Yeah, 15.75.
There you go.
All right, Nicole, I think you just rung a bell for me, which is when we get these desired dose on hand formula questions, we need to work that out to plug it in. Which I was confused about that before.
Okay.
And I think that was my biggest problem. So I think you just rung that bell for me.
Okay, fantastic.
Thank you.
You're welcome. Hold on, I'm looking for the other question that Andrew had.
So again, dose on hand is going to be the same as your concentration.
Yes.
Okay.
Andrew, you said the group because I just have the epinephrine one.
I'm sorry, the Zoom group one.
Ah, the Zoom group. Okay. Hold on. Uh, 1 gram per kilo to 176-pound patient. That might be the correct answer. The workbook, I might have had a small stroke. So, all right, you have to give 1 gram per kilogram for a 176-pound patient. What is the conversion?
80.
Okay, 80 kilograms times 1 gram per kilogram is 80 grams.
I don't think you're sharing your screen, Nicole.
Curses.
Yeah.
Thank you. There you go. So as I said, yeah, so you've converted, right? So you're 80 kilograms, 1 gram per kilogram is 80 grams. If the question asked for milligrams, you could then convert it. It would be 80,000 milligrams. That help?
Yes, thank you.
So one other question, which I think I figured out in the workbook. No, first of all, again, let me ask the question. On the test, can we use the calculator or no?
I'm gonna recommend no, because if it's the calculator on your phone, you're gonna get jammed up that you are cheating because you're on your phone. That makes sense.
Right.
So I'm just gonna say no, just for your own protection for, potentially getting jammed up for quote unquote cheating.
Correct. Yeah, I'm just saying. I have a regular solar pocket calculator, which reduces my calculation time, like especially the volume over time, to almost nothing.
Yeah. Well, the problem is the state test is not going to give you a calculator.
Okay, so you can't have calculator. That's helpful to know.
Yeah.
And then, of course, the other thing in the workbook assignment I noticed is I didn't round up the number to the nearest whole number. So that's going to be required as well. I think it may have said it. I just didn't do it. I mean, I understood what the error was. My answer was essentially correct in the workbook. I just had to go back and change it to the
Mhm.
higher or the, you know, the rounded number,
Yeah.
basically.
I think so. I don't think that's going to be an issue on the test.
Okay.
I don't think rounding issues will be on the test. All right. Any other questions, thoughts, concerns? All right.